Before starting about the postgraduate, let me mention that in Khyber Medical University, the 100 hours curriculum, we have already developed that. And from the next year onward, every medical student and Professor Somya Iqtidar for arranging this session in the PSIM conference, because journalists and specialists, they go hand in hand. And I will tell you how much we supposed to have through evidence, how many trained journalists we need to have, and how many trained specialists we need to have in our country. So let's see. We all know the Prime Minister have the plan of achieving universal health coverage in the next 5 years, which means every citizen of Pakistan should have access to quality service without financial hardship. So just imagine, Professor Abdul was talking about palliative care. And then when I asked the question, even in Islamabad, you cannot get the essential end-of-life drugs. So how are we going to do that? So obviously, now we know why it is important to have trained family physicians so they can do every bit. And how are we going to do that? So the answer is, we need to change this pyramid. So this is our healthcare pyramid, where part of the funding, part of the training only on primary healthcare, but everything goes to tertiary healthcare. But if you go to a tertiary healthcare hospital, is it really a tertiary healthcare hospital? I visited Peshawar Institute of Cardiology yesterday. Everybody who got a little bit twinge here is now going to Peshawar Institute of Cardiology, which is a state-of-the-art tertiary care cardiac hospital. So is this the cost-effective model? We developed a tertiary care hospital in Sawabi, which is almost like within 50 miles of Peshawar. They've got 6 trained intervention cardiologists. They've got every specialty on earth, including even infectious diseases, which is very rare in other hospitals. But unfortunately, they still refer myocardial infarction to Peshawar. There's a very famous quote there, whatever they do, dexadecadron and then refer to Mardan. That's what every prescription that shows. So, unfortunately, we need to have, or fortunately rather, we have to change this health pyramid if we want a cost-effective model. And that's only possible through family practice approach. And why is family medicine? Again, because it's cost-effective. And it's not us saying. There's a lot of evidence, which I think Hina mentioned about Barbara Starfield. There's a lot of evidence from that, but now even recent evidence is emerging. And as we go along, I will tell you what other people are doing in the world. Capitation, again, even in UHC we are thinking to put $5 to $6 per patient registered. I think they are piloting in Islamabad. So that is again the most cost-effective model. And again, it's not me saying, one of the most senior health economist, policy maker in the National Health Ministry, who himself mentioned in one of the talk that the amount of money they spend in one hospital in Islamabad got only one public sector tertiary hospital, correct me if I'm wrong, they can develop the entire primary workforce or primary health care on the same budget if they want. So just imagine, again, continuity of care, again Professor Aziz mentioned, because he's your patient, you've been looking after him for years and years and years, and obviously you are there, at the time of dying, and nobody wants to die in hospital. Recently my grandfather died. Yes, he died in hospital, but what everybody was doing, they brought the cardiac arrest trolley, they wanted to take him to ICU, and I said no. Yeah, if you're not going to save him, then at least let us stay with him. So it is important, again, for the continuity, and the most important is gatekeeping role. Gatekeeping, again, health set-service card is coming. Again, unfortunately, is so many examples. I visited the same hospital again yesterday. Everybody is undergoing angiography. You got chest pain? Yes, you can have angiography because you got set-service card. We can charge from that. 80,000 going to be paid to the cardiologist. 2 lakh going to be paid to the hospital. So yes, everybody going to have. But is that the safe and effective and evidence-based medicine? No. Okay, so how much numbers we need if we want to achieve it? So ideal mode, it should be 1-to-1. If you have 100,000 specialists, by specialists I mean every specialty, you need to have 100 trained generalists. So if we look at Pakistan, this figure of 3 per 10,000, that is the WHO target, and we are signatory of that, which means we need to have at least 3 trained family physicians per 10,000 population. Again, my mathematics is not very good, but Pakistan, I presume, got 22 crore population. So if you calculate that, that is almost 66,000 we require. So we require 66,000 trained family physicians. And obviously, everybody knows, if you want to improve the quality of care, you need to bring family practice approach. So, family physician is again we're reminding everybody, he is not just a GP, he is the MacGyvers of the medical profession, because he provides breadth of care wrapped in a relationship. Again, Professor Abdul, coming back to your end of life care. So if you have that relation with the patient, only then you will be able to explain these difficult words, when the patient is dying. So again, when I become a GP, trust me, it was a conscious decision. As I mentioned earlier, as being Pathan, I wanted to become a surgeon, and I went there and I did my MRCS, and I was applying for a number, and then all of a sudden I got a number in A&E, and then I decided, hang on, is it that something do I really need to want to do? So it was a conscious decision, it was not by default. So I took that decision, working after 7 years in surgery, I decided to become a family physician. Because, yes, family physicians are experts. They are experts of preventive medicine. I think everybody is talking about preventive medicine. We definitely need specialists, and we have a lot of specialists, and very, very good specialists in Pakistan. There is no question about it. Even if you come to any city of Pakistan, even here, like we were talking about, how many, we had Professor Jalil, we had Professor Abdul, and a lot of senior Professor Abdul, and we have a lot of specialists. So that's not an issue. The problem is specialists. Which patient specialist is going to see? Obviously, if the patient has already got cirrhosis, and I know Professor Abdul is giving him a very best treatment and stuff, but if that patient was, during the time when he started developing an FLD, when he was getting a little bit of male very likely, so even if he was seen by a primary care physician at that time, who could have prevented that? So we wouldn't have been looking for turmeric now to sort out his hepatic problem. So again, underappreciated illnesses comes to us. Chronic disease management is very important. I give you an example. Recently, a patient who was referred by her own sister was a senior consultant, and she decided to refer her to me. So I was dealing with her diabetes, and her renal function was getting off and off, so I had to stop all the medication. On the third consultation, only then I managed to figure it out what it was. She was taking a lot of diclofenac, even diclofenac potassium, sodium 3 to 4 anti-inflammatory, which was prescribed by orthopedic. So when I asked that, look, during the drug history, I asked you, and you never mentioned these drugs. So I thought you may not need to know about this because you're a physician. And so that was the main issue of her renal problems. So this is the reason, why chronic disease management or elderly care should be managed by family physicians. Again, judicious use of finite medical resources. As a country, yes, we unfortunately is a developing country. We need a cost-effective model. We cannot afford to build tertiary care hospital in every city. And again, even if we build it, it's not cost-effective. So even the Sehat Sahulat card, we need to be very cautious, because what future going to do with that? The health insurance system in Gulf is changing now, because they want family physician as gatekeeper. Otherwise, they can't afford. So if they can't afford, how are we going to afford? Again, coordination between the healthcare team. Unfortunately, if you look at primary care, our specialist services are very good, no wonder. And one of the reasons is that specialists are involved in decision making. If you go to any hospital, medical director, DMS, ward chairmen, all of them are clinicians. But if you go to primary care, unfortunately, there is no clinician involved in decision making. So DHO, DVHO, they've got public health experts. Unfortunately, they don't have trained primary care physicians. Okay, now, why people don't want to become GPs? So this is the data from UK. So in UK, an average GP is earning 104,000, while a specialist is earning 114,000. So 10,000 pounds less, but still no night on calls, no stress of operation theatre. So not a bad idea, isn't it? If you want to become a GP in UK. Well, I was a GP, well not I was, I'm still a GP. I still practice in UK. And when you ask about will they choose the same specialty again, 77% said yes. So we have to remind everybody that I'm not just a GP, I specialize in awesomeness because I'm a GP. Okay, looking at career pathway again, yes, it's a specialty. You need to have some training in it. So these are again from different countries. If you go to UK, you have to do a couple of years foundation training, then 3 years of specialty training. The same is in USA and the same is in Australia. And I know somebody asked a question in Pakistan. In one of the meetings, we did discuss with the stakeholders or why not to consider a 3 years FCPS for family medicine. There's a lot of other ways which we're going to discuss, but why not? So this is how things work in UK. So this is my practice in UK. So what model we use in UK is a purchaser-provider concept. You're not a salaried GP. Well, some of them are salaried GP, but the way government pay them is basically you provide service, and for the service you get paid, but you also get paid per registered patient. And you get extra payment if you do something good. So if your patient diabetes is well controlled, you get a bonus for that. So if I give you an example of this is my practice in Halifax, we hired a diabetes specialist nurse. And because we got a lot of diabetic patients, a lot of Asian population, a lot of Eastern European population, and it's a very cost-effective model. Plus she had a very good relation with the hospital endocrinologist. So we are offering type 2 diabetic services in the primary care. So a lot of our patients don't need to go to hospital, they don't need to be referred. Now we got telemedicine, we got electronic medical records. So in UK we can certainly take advantage of the specialists. We can do e-consultation with them. We can do even the referrals are now made electronically. But yes, we need to ensure quality. As you said in Pakistan, obviously it's a risk. Then people obviously you need to know your limitation. When you have to refer to specialists, what you're going to do. So again, you need to impose similar sort of quality control. In UK, we call it CQC, Care Quality Commission. I work for them as advisor. Then in the second picture, this is out of hours GP. So we have this car, we go to patient house. Again, I will mention to Professor Abdul, when we have to visit palliative care patient, even out of hours, midnight, 2 o'clock, 3 o'clock, I visited, to declare death, to see them when they are dying. So that's what we do. Now, if you look at Gulf, so people around the world are doing it. I would say, I hope I'm wrong, but it normally takes 50 years. But this time we are a bit fast forward, and again thanks to PSIM for giving us opportunity and a lot of other forums, and we are grateful to all these family physician association who are taking our demand to high ups, and things are changing. So if you look at Gulf, this is Gulf. In Gulf they realized after putting the health insurance and bringing all health insurance, after 1 year or 2 years they start getting problems because there were unnecessary tests, untrained family general practitioners. So obviously they realized something. They have a lot of specialists, they have a lot of specialist hospitals. So what they decided to do was, they found out that this is not a cost-effective model. So they started opening primary healthcare centers run by trained family physicians. I worked myself in Qatar for 3 months. So this is Doha. So in Doha, they've kind of brought almost 200, I would say, sorry, isn't it? 200 GPs from UK. And if I tell you, more than 50 to 60 persons are Pakistani origin. So, we can do it. So if we are doing it there, why can't we do it here? So that's what they learn from there. Unfortunately in Pakistan, when I was leaving for UK after my MBBS, this was our primary healthcare centers, and tell me if it's been changed in the last 30 years. I don't think so. So what we need to do? I said we can't wait for 50 years. 1992, Aga Khan started FCPS in family medicine. Okay? 93, program was started. 2020, unfortunately we only have 100 FCPS. Again, more than half of them are working in Gulf or Australia or in other countries. Okay, then obviously people realize it's important. We start working on other programs, short-term programs, bridging programs, and MCPS, big lots start coming out. Again, even MCPS are only 160 per year. And if we go back to that figure of 66,000, so how many years is it going to take us, Tarizal? I think more than 100 years, and we cannot afford that. So now we are running diploma programs, we are running membership of 2 years, fellowship, but the fellowship take is only 10. MD program take is only 6. And if we want to attract young trainees to adopt this as specialty, we need to incentivize it. So this is Dr. Khan's 5R formula. I know I must have been presented in other conferences as well, but I will go back to it again. If you want to recognize the specialty, if you want to develop family medicine, you need to follow these 5 R's. So you need to give them respect, you need to give them recognition, you need to reward them, to retain them, and only then they will give you results. So now, when we talk about respect, what respect we want? We want same respect as other specialists. We want training slots in family medicine, in tertiary care and primary care. We want specialty TMOs to have clinical rotation in primary care. So they learn what GP has to do, how they have to, what he has to deal with. Again, specialty TMOs need to go there, and we need to define boundaries. Because to be honest, even a lot of people, can't even figure out what is family medicine and what is internal medicine. So it's a big confusion, so we need to define that boundaries. Recognition, again, there need to be a national directorate, family medicine specialists scattered, like I mentioned, at BHU levels. We need to get recognized at undergraduate curriculum, and we need to provide postgraduate training slots. Okay, so once we train them, what are we going to do with them? That's the question. I'm here for the last 3 years now. What my main worry is, I've trained around 100 people. Unfortunately, or fortunately, 5 to 6 are leaving for Kuwait. So, yes, it's good. They're going to bring a lot of money to Pakistan, but they're not going to help my people. So if I'm going to do the same job, why can't I do the same job at 20 times better salary? If I'm training doctors for Gulf, I might as well go there and train them there. Because I'm training them here because I want them to stay here. So to retain them, what you need to do, you need to give them job opportunities. You need to provide them training structure and choice of work area. If I belong to Gujranwala, why are you sending me to Lala Musa? You know, if you look at the government thing, why can't you send them to add to their own birthplace? And we need to sign legal bonds with them, because this is another issue. Because people are going to leave, you're going to train them, you're going to pay for their training, you're going to offer opportunity, and they're going to leave. So one option could be keep them in the same primary healthcare center for at least 5 years. And I think in KP they are thinking on it. What reward we're asking for is not just the money, but paid training like any other specialty, and incentivize the course fee. Penalties for not having training. Jordan is thinking that nobody after MBBS will be able to open a general practice clinic. They have to have at least 18 months of training. And also support for regular CMEs. For private GPs, they're doing a lot of work for us. I think more than 70%, if I'm not wrong, people go to private GPs. So what are we offering them? They're offering us the service. What are we offering them? Obviously they're busy. Luckily, obviously, a lot of them could have come here, isn't it? But unfortunately, they will be even today, fortunately, sorry, providing care. But we need to provide the support for their regular CMEs. And then ask for results, yes. We need to improve service delivery. We need better care for our people. We need to reduce referrals. We need to increase patient trust. And that's how we can do it. So once they complete their training, again, same respect. We need to develop a family medicine cadre. We need to create job opportunities. We need to have bonds with them. And having said that, again in KP, they are thinking of upgrading 200 BHUs. So we have requested, if you are upgrading them, upgrading doesn't mean like, bring a new table. But you can put trained family physician in. So, better salary package and allowance, why can't we give them? In KP, there is a project run by a donor, they call it AIT project. And they are paying emergency medical officer 3 lakh. They are paying a medical officer 2 lakh. The problem is, we were asking them, rather than give a normal medical officer the salary, you develop a family medicine post and then offer the salary and make them in charge of that BHU. So he can stay there. What happened now is they increased the salary, but it didn't work. Why? Up till now in BHU there was only 1 doctor. So he was doing at least 3 days a week or 4 days a week. Now they put 3 doctors. So what are they going to do? They divided the rota, so now they are doing 1 in 3. So they are only going there for 2 days. The same is for casualty medical officers. They are doing 1 in 7. So they put 7 medical officers, paying them 3 lakh, 21 lakh. And they are not working because people have still no trust in BHU, no trust in THU. So if people are still going to Peshawar, what's the point putting them in these areas? So again, only if you give them this reward, they will be able to give you the results. Now, what's the way forward? They need to have sponsorship and ownership from the health department. We need to identify primary healthcare centers as training facilities. So both undergraduate and postgraduate can go there. We need to incentivize those who complete their training. Post needs to be created at RSC and BHU levels. While talking, a lot of tertiary care hospitals have realized now, Lady Reading Hospital in Peshawar, who got a very big emergency of more than 5,000 people come to emergency, visit emergency department of LRH. They realize it's not cost-effective model because everybody chest pain coming to A&E, what they are doing is obviously all the tests. So they have opened a family medicine department in Lady Reading Hospital and they are diverting patients there. And this is not something new we are doing in Pakistan. When I mentioned Gulf, the first job I did in Qatar was in Ahmed Medical Corporation. And HMC, again, they had a very big A&E, but a very big influx of labor who work there. So when the bus take one patient, so the rest of them are in the same bus because they are on their way back from work. So everybody just ends up in A&E. So they realized that their A&E doctors cannot cope with them. So they brought again GPs from UK to run their A&E department, especially the minor area. So the same model needs to be implemented in all districts. While talking, WHO has piloted 12 districts across Pakistan and now piloting more for family practice approach. They are supporting them, they are developing medical records. Up till now it was a paper record, but now it's going to change to electronic medical record. Again in universal health coverage now. So things are moving forward. Luckily in KP now I'm in the technical advisory board and I think Hina is in Punjab. So we are trying our best to look at the essential health service package and to ensure that family physician posts have been created. In Islamabad, again, Tehzeem is here sitting here, and I know the reason I didn't put that was because they are still in the draft stage, but I think I can mention it that for the training, they are thinking to localize a special budget for family medicine training. So things are moving. And the last but not the least, we need to create a reference system. Unfortunately, hospital MTIs are coming. We are expecting our professors to sit in OPD, but for what? I asked the gynae professor and she said, look at my OPD. This lady came to see me for what? To do a pregnancy test. So, yes, we need consultant-led care, but we need to identify that a professor will have an OPD, they will see 25 to 30 patients and only those patients who need tertiary care. So if a proper referral system is created, only then is possible. So again, respect, recognition, reward, unless we mix that, we're not going to be able to retain them and give you a result. Now, people do think like, whether we can do it or not. I showed you that girls do it, but we need to change our work attitude. We need to put more money on primary care. So we need to have that Japanese attitude. If one can do it, I can do it. If no one can do it, I must do it. But we have to come change our, unfortunately, Middle Eastern have already changed. So this is us. Wallahi, if one can do it, let him do it. If no one can do it, yeah, maybe how can I do it? So we need to change that attitude, and we need to become a bit of adopt the Japanese attitude. I know it's a long way to go, but I'm already so far from where I used to be, and I'm proud of that. Thank you very much. If you have any questions or